extrathyroid extension carry a worse prognosis. So tumors which are intrathyroid, uh, anywhere from up to 4 centimeters, if they are within the capsule of the thyroid gland, have an 88% 20-year survivorship compared to those which manifest extrathyroid extension at initial presentation. Quite in contrast, multifocality of the primary tumor has no impact on prognosis. And similarly, none of the previously reported prognostic factors have shown that multifocality is an important factor giving an adverse impact on outcome. We looked further into it and we noted that the majority of patients with multifocal tumors were young patients. So multifocality is a phenomenon of papillary carcinoma in the young. Rarely you see an 80-year-old presenting to you with papillary cancer which is multifocal. So it is the patient's age which supervenes over multifocality and hence no impact on outcome. Similar to multifocality, nodal metastasis in general has very little impact on outcome. In fact, the two lines at 20 years are superimposable about patients who presented with nodal metastasis and those who did not. Again, looking further into it, we saw that a majority of patients who present with nodal metastasis are young patients. So keep in mind two parameters, multifocality and nodal metastasis are features of papillary carcinoma of the young. If you look more into detail and break the patients who come with nodal metastasis by their age groups, and that's what is shown here, you do find the adverse impact on outcome on patients who are older and who present with lymph node metastasis. Younger patients with lymph node metastasis at presentation have a 100% 30-year survivorship. This is not 20. Now we are at 30 years. At 30 years, not a single patient under 45 who presented with lymph node metastasis died from papillary carcinoma. On the other hand, only 80 or 78% of older patients were alive long term if they had lymph node metastasis. Distant metastasis clearly will have an adverse impact on outcome, understandable, and that is depicted on the graph on your right. Now, how do we use these prognostic factors in devising a treatment algorithm? Utilize these factors which are related to the patient and the tumor in devising risk group stratification. And here you take factors related to the patient, which is the age and gender of the patient, and factors related to the tumor, which we call tumor factors, tumor size, extrathyroid extension, histological grade, and presence or absence of distant metastasis. So based on these patient factors and tumor factors, you can come up with a high risk group and a low risk group. Low risk groups are patients who are under 45, generally females with smaller tumors less than 4 centimeters, T1 and T2, which are intraglandular, with a well-differentiated histology and no distant metastasis. Low-risk patients in general have an outstanding long-term prognosis with a risk of cause-specific death of 1% or less. Three groups reported here: Memorial, Mayo Clinic, Lehigh Clinic. Mortality in the low-risk group is 1%, 2%, 1.8%. In the high-risk group, which are older patients with either poorly differentiated histology or extrathyroid extension or presence of distant metastasis at presentation, have a significant adverse outcome with only 43% and 46% long-term survivorship. It is these group of patients where we need to spend more time, effort, and resources if we are going to make a difference in the outcome of thyroid cancer treatment. Keep in mind, majority of patients, somewhere between 70 to 80%, fall into the low risk category. So it is the last 15 to 20% of patients who fall into the high risk group which require intensive treatment surgically and intensive treatment with adjuvant therapy. There is an intermediate risk group which falls into the following categories. Young patients with bad cancer or older patients with good cancer will fall into the intermediate risk group category, where you need to exercise judgment and discretion in selecting appropriate treatment. If you break them down by risk group stratification, in our series, 40% of the patients fell into the low risk category with 1% mortality. 22% fell into the high risk category with one-third death due to disease, and another 40% fell into the intermediate risk group category with approximately 10% loss of life. If you look at the outcome by risk group stratification in the Mayo Clinic data, over 2,000 patients, 2,300 to be exact, in the low risk group, cancer-specific 10-year mortality is 0. You can't make it better than that. However, the argument often given is that these patients do not die from cancer, but they do develop recurrent disease, and therefore we need to intensify treatment. So we look further into the subsequent behavior of thyroid carcinoma according to risk group stratification. So here is low risk group, intermediate risk group, and high risk group. In the low risk group, overall treatment failure occurs in about 13% of patients, rounded up to 10%, majority of which is by lymph node metastasis, which do not carry adverse impact on life. So these patients will require secondary treatment, but they won't die from cancer. So even though treatment failure occurs in about 10 to 13% of patients, rarely ever these patients die from thyroid carcinoma. In contrast, in the high risk group, treatment failure occurs in every other patient. 50% of the patients will fail initial treatment. Majority of the treatment failure occurs with distant metastasis, which is the cause of mortality. And again, it is this group of patients wherein we need to spend more time. So simply crystallizing what I have told you so far, in selecting therapy in adult patients, if they fall into the low risk category and if they have a unifocal single nodule intraglandular tumor at any age group, simple surgical lobectomy should be curative. In contrast, if patients fall into the high risk category by any of the criteria we described, at any age group, they require aggressive surgery and aggressive adjuvant treatment. Take for example two scenarios here, intrathyroidal single nodule, maybe a microscopic focus here, or a single nodule up to the capsule with minimal surface extension of disease is curable by a simple lobectomy. On the other hand, gross extrathyroid extension, bilateral gross tumors, bilateral nodularity regardless of their histology. If you got thyroid carcinoma in one lobe and you got multiple nodules in the other lobe which are gross, that patient should undergo total thyroidectomy because you don't know what those nodules will be. If the patients already have clinically appreciable nodal metastasis, they will need total thyroidectomy because of the need for adjuvant radioiodine therapy following surgery. Total thyroidectomy, according to the principles followed in our institution, are indicated in the patients who have diffuse bilobar tumor. There are bilateral nodules regardless of the size of the primary. If there is major, meaning gross extrathyroid extension, or massive bilateral nodal metastasis, presence of distant metastasis, or history of previous radiation exposure. The debate about lobectomy and total thyroidectomy in single nodules occupied conference time for nearly 30 years in many national and international meetings. We did a study comparing lobectomy and total thyroidectomy on a matched pair analysis, and the reason for that is a prospective trial will never happen. You need over 8,000 patients followed for 30 years, and that's not going to happen. But in a matched pair analysis, the survivorship at 20 years between lobectomy and total thyroidectomy was superimposable, the blue and the green lines. Not only survivorship was comparable, tumor recurrence behavior was also similar. local, regional and distant failure